Now I would like to just briefly introduce our experiences and how we shifted to an open repair to an laparoscopic repair in morgagni hernia. And as you know, the morgagni hernia is different from the Böhtelek's hernia, which is retrosternal. It's called an anterior diaphragmatic hernia, and it constitutes to 2 to 5% of all diaphragmatic hernias. It's anatomically, if the defect is on the right side, it is called of hernia of morgagni, where it's on the left side, it's called of the lare. And you know, the open repair is very classical, and that has been done for many years, but now there's a chance of laparoscopic repair starting from the children. It's about 2000. And the first one is about the continuous repair. The other one is intracorporeal interrupted one. And now we are talking about the extracorporeal one, which is interrupted also. The aim of our study was to compare the results of the laparoscopic and open repair, which was done in our department. And as a method, we just look back to 2022 and it will be 24. And we will evaluate the demographic features, clinicals, diagnostic tools, surgical options, and postoperative outcomes. As you can, this is one of the common presentations on the anterior posterior chest X-rays, but if you're suspected any kind of morgagni hernia, you need in a lateral view to define the morgagni hernias. When we look at the years, we started with 2018 to 2024. The first part has some open repairs, and we started with laparoscopic intracorporeal repair, which was 3 cases during this period. We exclude this because we want to discuss about what was the transfacial knot tying method is working. Then after 2020, we used to have some laparoscopic transfacial knot tying repair. When we look at the results, we have 16 pages. Patients, 8 of them was open repair, 8 of them was laparoscopic repair, and most of them were girls. And the mean age of diagnosis and the operation was 9 months. And when we look at the open repair group, the 25% of cases were found incidentally because they have some checked X-rays because of other reasons. But for the patients with the incidental has statistically higher rates of incidental cases because some of them is also diagnosed during another laparoscopic procedure. And when we look at that, the associated anomalies is very high in open repair when compared to the laparoscopic repair. Now, you know, there are some steps of the procedure which you can do a laparoscopy. This is the basic principles that when you do a laparoscopic procedure, the first thing is of course, the reduction of the colon. The colon is the most part that and goes up. And then some surgeons use inserted traction suture just in the middle of the defect. So they think that it's easier to put the other sutures on this side afterwards and finish it. So we can use the extracorporeal or intercorporeal interrupted bone sutures, and it depends on your endoscopic skills or laparoscopic skill, your preferences and your experiences, whatever it is, but the thing is that you have to close the defect. The thing that the laparoscopic transfacial knot tying is a little bit easier method to use. You put a camera in the umbilical port side, and just sometimes a single port is okay. And then you can put a needle, and through the needle, you can pass the needle from both the fascia and then the diaphragm, and then you can take that needle, take that suture back to outside, and you can tie them and just to move it on the transfascia. This is very easy, and almost sometimes you can use it according to the size of your defect. You can put 3 or 5 of them, and it's very easy. And all the knots are on the fascia and under the subcutaneous tissue. So it is very easy to do that. You don't need to do something intracorporeal. Just to put the needle down and put the needle back will be okay. So when we look at that, none of the cases need a conversion to the open repair. And we have, in 2 of the cases, we need a sac, the sac was excised, because it is not mandatory to excise the sac, but if the sac is very big and if you cannot see clearly the rim of the diaphragm, sometimes you can do that. But when you leave the sac, there is another problem, is that if you leave a big sac without leaving, when you have a postoperative chest X-ray, some of the pediatricians think that you have a recurrence. So therefore, if it's too big, you can do that. And as in surgery, everything is okay. If it's true, if you excise, if you do not. And this is another paper I just to bring out from Ankara, not our department, from the other university. They have lap-assisted anterior transabdominal loop suture. They make this modification, and it's a good modification. After this presentation, I also used it one of the patients. As you can see, they put the needle, same as we did, but they put a loop, as a loop suture, and it's very easy. You can put it in the needle. Then they have another suture and take that suture inside the loop, and when they pull back, the same thing happens and the knot is tied again. So this is another procedure, just a different modification that use is a loop, which is very commercially, it's available loops, they can use that. As you can see, this is usually we can have the diagnosis with the two-sided X-rays, chest X-rays. Sometimes some patients has chest CT scans, but they are usually the incidental findings, because this CT scan is not done for diagnosis of morgagni hernias. It's obtained for another reasons. There is no intraoperative or postoperative complications, but we have 2 recurrences in patients with the Down syndrome after 6 months after the repair, and there is no difference between in terms of recurrence or in terms of outcomes for open and laparoscopic repair. But it's unfortunate that we have 2 patients with recurrence. It means it's a little bit a high number of patients when you have a small group of patients, and most of the 2 of the cases were Down syndrome. There is a discussion about the minimal invasive surgery and open surgery for morgagni hernia. As all other minimal invasive surgeries, it has the advantage of shortened length of surgery and hospital stay, less small bowel obstruction, but still has the high recurrence rate when compared to the open repair. This is a very good systematic review and meta-analysis done. Is a huge number of patients. It's almost 300 patients. And they found that there was no difference between open versus minimal invasive surgery. And they found that the patch repair has less recurrent rates. But you can use patch. Almost none of the patients in our series need a patch to repair. But if you want to use the patch, it's not also very difficult, because when you put a transfacial in needle, you can also at the same time go back from the graft or the patch at the same time. As a conclusion, despite we have a small number of cases, we can conclude that the laparoscopic management of morgagni hernia with the transfacial knot tying is a really easy and effective method in the management of children with morgagni hernias. But the recurrence after laparoscopic repair seems to be the most important problem, especially if you have a baby with a Down syndrome. And thank you very much, and thank you. And you can see again, this.